I'm Tonda Hughes, and I'm the Associate Dean for Global Health at Columbia University. And before I went to Columbia, I was Associate Dean for Global Health at the University of Illinois at Chicago. So my close colleague and friend, Linda McCreary, who can't be with us today, is now in that position. And she and I met first together and then with Jennifer and some others and talked about launching this speaker series to highlight the role of nurses in global health. So that's what we're doing. And I'd like to get started by introducing our speakers today. And we hope to do these, just so you know, about every 2 months. We don't have the topic or the date selected for the next one, but we will use the same methods of communicating, of getting the information out. So, you know, just keep your eyes open. You should see something coming relatively soon. Okay, I'm excited today because I know one of the speakers fairly well from my faculty time at UIC, and I've met Rohan and have come to know him a bit more just in the last few months. But Rebecca Singer is, as a doctor of nursing practice, she's a registered nurse who teaches population health at the University of Illinois at Chicago College of Nursing. She draws on more than a decade of experience in global health and community partnerships. She has, her work has taken her around the world to conflict zones, post-conflict zones, and other unstable regions where she's collaborated to provide essential health care to individuals, families, and communities in crisis. As an example, Rebecca has partnered with coffee farmers to prevent cervical cancer and to improve their lives and livelihoods. Domestically in the US, she's worked with torture treatment centers, correctional institutions, and reproductive health clinics, providing care that enhances health and dignity. During the COVID-19 humanitarian crisis in Chicago, Rebecca has been involved in various community-based projects, including University of Illinois Health's program, employee testing. She's also worked with testing and vaccinating individuals in the Chicago area, particularly focused on community congregate settings such as homeless shelters, long-term care facilities, residential treatment centers, and correctional institutions. Welcome, Rebecca. We're so happy to have you with us today. Dr. Rohan Jeremiah has a master's in public health and a PhD. He's a global health scholarly practitioner with training in applied medical anthropology and in health behavior and health education. He's associate professor of human development and nursing sciences at the College of Nursing at UIC, and also associate director of the Global Health Leadership Office there. He is an elected fellow in the Society of Applied Anthropology. Dr. Jeremiah's scholarship reflects more than 20 years of global health experience, including Peace Corps volunteer services in Cameroon and South Africa, and project development and management throughout countries in Sub-Saharan Africa, South Asia, Latin America, the Eastern Caribbean, and the United States. He has served as a technical advisor to the United Nations, the United States President's Emergency Plan for AIDS Relief, PEPFAR, and the U.S. Agency for International Development, USAID. He has held faculty appointments at St. George's University School of Medicine in Grenada, West Indies, the University of West Indies, St. Augustine in Trinidad, and St. Louis University College of Public Health and Social Justice. His research is at the intersections of substance use, violence, and HIV and AIDS among marginalized and vulnerable men. Recently, Dr. Jeremiah's research activities have focused on the health and well-being of resettled ethnic minority refugee men in the United States. Welcome, Dr. Jeremiah, Rohan, and I don't know which of you plan to start first, but please, let's take it away.
Right. Thank you so much for inviting us and for having us and for everyone joining us. It's really exciting to be able to do these things. Technology can be a real pain during COVID, but it actually also brings us together from across the country and around the world. So thank you so much. And I'm going to share my screen. we go. Can folks see that? Okay, great. So today, Rohan and I are really excited to collaborate on this talk because I think we bring together, first of all, a great deal of experience, both domestically and abroad, working with refugees and asylum seekers. But I also think we bring unique perspectives as both practitioners and researchers. He's much more of a researcher, I'm much more of a practitioner, but we both have experience in each other's sort of work. And I think that hopefully we'll be able to take you on a journey from where the refugee and asylum seeking journey starts, working here towards the United States and resettlement here. So we're going to start by defining the terms, just to make sure that we're all on the same page. We know that the way that these terms are used is sometimes interchangeably, or they are co-opted for reasons to make a point, but we just wanted to sort of level set and set the stage, and using the definitions of refugee, asylum seeker, internally displaced persons, and then stateless individuals. And we're, although all of these are based in international law, each country does have its own term in their legal systems. But this is based off of the UNHCR, the United Nations High Commission on Refugees definitions. So basically, a refugee is a person outside their home country who has fled their country and seeks protection because they cannot return due to a well-founded fear of persecution. And it can be for many reasons, but it could be, for reasons of race, religion, nationality, political opinion, or membership in a particular social group. Obviously, international law has worked to define what those all mean. And then an asylum seeker is a person who also flees their own country and seeks sanctuary in a country, and then once they get there, applies for refugee status, and thus the legal protections that being a refugee affords. So really, when we're looking, and I'm going to be very US centric right now, because I think that that's where we are based. That is where we're doing our work, and many of us on this call are practicing. That when we think about a refugee, that is someone that fled their home country, went to a second country, got processed, were deemed to deserve protection, they cannot go home, and then they come to the United States with all of those legal protections as a refugee. An asylum seeker, everything is the same, except that they arrive in the United States prior to getting that legal protection, prior to the designation of refugee, and then they do go through the system here in this country. Okay, so that's often the difference between the two when we're talking about immigration here. And then internally displaced persons are people who are forced to flee their home, but do not cross an international border. And so they can spend lots of time in their own country, which means that they do lack a lot of those protections that refugees and asylum seekers have. And then finally, there's a group of stateless individuals, which are persons that are not considered as a national by any state under the operation of its law. And I did a very interesting deep dive rabbit hole into stateless individuals and the reasons that this happens. And often it's myriad of reasons, and it can be because of where they were born, sort of falling in between different countries' rules on who gets to be a citizen, but it can also be because of changing borders, or because a government decides that they don't want to serve those people. They no longer recognize them as citizens of their country. Right now in our country, there's a large group of Rohingya refugees. They are stateless peoples, as are Palestinians, and there are many other groups of people. So obviously, this is not an international law course, but we did want to give you this background so that you would understand what we're talking about. And when we look at the numbers and we talk about this whole group as a whole, we talk about them being forcibly displaced people. That at the end of 2019, we had 79.5 million forcibly displaced people, which is pretty much the highest ever. And we can look at where people are and the top source countries. And over the past few years, they have been Syria, Venezuela, Afghanistan, South Sudan, and Myanmar. And when we think about and reflect on the conversations that we're having in our country about refugees and asylum seekers, you would think that we were an enormous host country of refugees and asylum seekers. But when you look, really the top hosting countries are Turkey, Colombia, Pakistan, Uganda, and Germany. So it's countries that are proximate to the countries that are producing the refugees often. Other than Germany, which obviously took in a great deal of refugees during the Syrian crisis. So they were a little bit further. So this is information from the UNHCR, which is fascinating, and recommend people looking into this work. So now that we've sort of set the stage for what we're talking about, I'm going to talk for a while about what happens in the health needs and what's happening with people in the earliest stages of migration before they resettle. And then I'm going to pass off the baton, and Rohan's going to talk about resettlement and issues that refugees and asylum seekers face here. And then at the end, we'll talk about bridging those transitions, okay? So I want to set my disclaimer as I'm going to talk about healthcare service provision during displacement, and say that this is really based on my practice. I have practiced as a nurse in complex humanitarian crises, mostly with Doctors Without Borders, MSF, since 2005. And this is what I'm going to talk about is really grounded in that practice and things that I have seen and witnessed and experienced and tried to do, and sometimes actually did in these complex humanitarian crises. Further disclaimers are that all the work that I've done with this population has been in sub-Saharan Africa. So it is very specific to the experiences there. I've worked with refugees and asylum and displaced peoples in South Sudan, Chad, Cameroon, Zimbabwe, Tanzania, and Uganda. I think that that's about it. And they are very different countries with very different health systems, the different types of populations that I've worked with. But there are some commonalities, and they are very different than the people who have experienced more in the Middle East with Syrian and Iraqis, or people from Central America who come from countries with extremely sophisticated healthcare systems and sophisticated, experiences with healthcare. It is different from a lot of the places I've worked, which has been in very rural parts of sub-Saharan Africa. So you might see some commonalities, but if you're like, that's not what I saw in Turkey, well, you're right. It's probably not what you saw in Turkey, but hopefully we can all learn. All right. So when we are doing work in complex emergencies and working with large groups of displaced people who are either in some sort of official refugee camp or an official internally displaced persons camp, or unofficial, a large grouping of either refugees who set up their own homes along a border, or people that seek safety in some sort of village away from where the fighting is. We are talking about huge groups of people that went from a settled sort of place and came into a new place that already had a host population, and they often destabilize it, right? And so when we are trying to think about those health needs, it really is just trying to meet the very basic health needs and really looking at those primary healthcare services. So a little bit of prevention and a lot of just trying to meet those acute needs. And unlike primary care here in the United States, in the situations in which I've worked, we're also not often able to do the bread and butter of primary care here, which is management of chronic illnesses. We're really often focusing on hitting those acute healthcare needs. So lots of people with upper respiratory infections, GI issues, some maternal child health, the basic infectious diseases, and lots and lots of them where I have worked, lots of malaria. And so really trying to meet those immediate needs of people and try to get people stabilized in their journey. In the very, very, very early stages of displacement, we do see people with injuries related to war or torture and the flight, but really that ends up being a very small portion of what happens. And it's more just the general things that one sees in primary healthcare, as well as like the disease processes I just talked about, as well as sort of accidents and injuries related to accidents. So that's really what the focus is often, and really trying to meet those minimum needs and those minimum standards that we can in order to provide this big care. But what I've really found is that in doing that work and providing that primary healthcare services, it ends up being a really good gateway to try to identify the specific needs of populations that we're working with, and then trying to tailor the work, what we do, to meet those specific needs. One thing I also want to say is that in trying to provide this primary healthcare, we understand that people's needs go beyond things that can be managed in an outpatient or even a very basic inpatient clinic. And so in all the work that I've done, part of setting up that primary healthcare system is also referral to higher levels of care when possible. So obviously, you know, people have emergency obstetric needs, they have appendicitis, they have broken bones. And so often trying to refer to the existing health services or higher level services. So, and then, as I said, there's very little chronic care. And for many of our populations that I've worked with in a place like South Sudan, they weren't used to chronic care. So it doesn't, it's not as much of a notable loss. But in other places I've worked, when I worked with Zimbabweans crossing the border into South Africa or in Cameroon, where those healthcare systems were much more stable and people were getting care for those things, that's a great loss. And ends up being on top of it is that you have people whose care for their chronic conditions suddenly stops. And that can be really challenging. So I'm going to look at a couple of case studies to sort of talk about how, in my experience, we've used this primary healthcare services as the gateway to try to determine and be able to offer some specialized services to these populations. So the first one is Nyarugusu camp in Tanzania, and this is 2015. I don't know how many of you have been there. It's one of 3 or 4 very large refugee camps in Western Tanzania near the Lake Victoria. And this camp was established in 1996 to meet the needs of refugees fleeing from the Democratic Republic of Congo. And the population when in 2015 was extremely stable. It had been there for 20 years, which is not uncommon. Most of us think about a refugee camp or think about refugees coming to the United States. We think they fled the war yesterday and they arrived on our doorstep today. And that's actually not. What happens is that this period of displacement prior to arrival can be decades long, and on average is well over a decade. And in this camp, people had been there already for a generation, you know, born and bred in this camp, and it was extremely stable. And then in mid-2015, due to election-related violence in Burundi, over 85,000 people fled into the camp within a 3-month period. I like to think of this, especially for our Chicago-based folks, is as every single person living in the suburbs of Chicago suddenly within a 3-month period moved into the city proper, and now we have to accommodate them, right? So crisis. And it obviously overwhelmed the resources in the camp, including food distribution, housing, and healthcare. This had been a very stable community. It was a refugee camp, but it was very well run. It was very comfortable. It was, you know, there was a strong economy in it. And so suddenly you can imagine the chaos that this formed. And what happens when you have all these people come in? The impetus for Médecins Sans Frontières, MSF, the group that I was with, to come in was actually some cases of cholera that had been identified in people transiting from Burundi. And thus we started to do a mass vaccination campaign in the camp. And I'm not going to talk that much about that campaign, but I am going to say that that sort of infection prevention and prevention of epidemics is a huge part of this work in refugee camps and during displacement, is just to try to keep those situations down. And so we got there for the cholera vaccination and then set up mobile clinics to provide primary care in this in the camp that had clinics already, but they were just overwhelmed. So we were focusing on the Burundian refugees as opposed to the settled population. And we found by doing basic primary healthcare consults and doing mass screening of children, we found two major problems that we wanted to address. And in this case, these specialized needs were malnutrition and then sexual and gender-based violence. And I think it bears mentioning, like, we could teach an entire course on every single one of these slides. And so we are flying through, I know, so save it for the question period. Malnutrition is a really complex process, and often there are many, many causes for it. It usually doesn't go from one day to the next that a child becomes malnourished. It happens because they're sick, they have TB, they have HIV. It can happen for social reasons. A mother dies, her children are taken in by someone else, and they are within the same family, other kids are healthy and some kids are denied food. And it can also happen that governments use food as a weapon and for punishment. And we've definitely seen that in lots of wars. And we noted pretty quickly that kids were getting malnourished that had come from Burundi. And it didn't quite make sense because there was food in the camp. It's not the best quality and not enough, and that's a common thing for refugee camps around the world, but it was enough that we shouldn't have seen such high levels of malnutrition. And what we found by talking to people is that there's such a stress on the land in Burundi. Burundi is a very, very densely populated country with lots of land issues, that people were already living so precariously that when they fled, it just put them over the edge and these children started showing signs of malnutrition. So we set up an ambulatory feeding centers, and we set up an inpatient feeding center, and then supports for the mothers as well to help support them through this process. It's obviously devastating for a mother to have a child diagnosed with malnutrition. And so we set up that, and that was open for many months before we were able to stabilize the situation. And the second thing that we found by talking to people and in our primary healthcare was that there were a lot of people that had suffered from sexual and gender-based violence. Now, obviously, it's very commonly known and discussed that rape is used as a weapon of war, and that is true. And also that often in periods of chaos and displacement, that people take advantage of the situation. And, there is a lot of sexual predation, and people, women in particular and girls, are victimized and experience sexualized violence. But when you get into camps, you constantly hear these rumors of people getting raped when they go out to get wood, when they go to get water, or when they're walking around in the camp at night, going to the showers or the toilets. And so I've heard this everywhere. You read about it in the news. It's a very common story. And so we heard this in the camp, and we started doing community-based meetings with mixed groups. And we also did a bunch of focus groups with women. And they told us that story. And then, we were like, okay, great. And then we were like, so do you know anyone that this happened to? And to a person, it was no. They were all rumors and stories they'd heard. And not to say that it didn't happen, but when we started digging deeper about what was happening, what we found in this camp was that, and I know that this happens in lots of places, is two things that were happening. One is that young girls were being married off, forced to marry, because they would be then one less mouth to feed for that family because they are now their husband's responsibility. And also that there is an exchange of money often and goods when someone gets married. And so the family would also make money in that moment. And they were so desperate to do so that they were willing to sell off their young daughters, often against their will, interrupting their schooling and putting them obviously at risk of problems later. So that was happening. And then the other thing that was happening at this camp, which is also very common, is transactional sex. So sexual exploitation, in which women and girls were being told, we'll give you food, we'll give you a job if you have sex with me. And this was something that we found in our own staff. And then we found that it was rampant within the camp in general with lots of organizations, was that people were exploiting women and saying, we'll give you extra rations or we'll give you a job if you sleep with so-and-so. And so there was a big we dealt with it with our staff, and then in the camp in general, there was a big effort. But those are really common things that can be seen. And if you don't sort of go below the initial sort of story of the light at night, lack of light at night, you're going to miss these other things. But through our conversations in the primary care, as well as in these focus groups, then we were able to identify and then set up and bolster the sexual violence response that was already existent in the camp and offer more supports. So that was Tanzania. And I'm going to move to a very different situation, a little bit further to the west, to Cameroon in 2018. So I worked in the Anglophone region of Cameroon in 2018, based in a city called Kumba. And I was there during the very early stages of a civil war that is ongoing, in which Anglophone Cameroon is parts of it are trying to break away from Francophone Cameroon. And so there was a growing population of IDPs within the southwest and northwest regions of Cameroon, which were the English-speaking areas. And people were being forced out of their homes and out of their farms deep, deep, deep into the woods, and also, or some of them into the cities, but some were even fleeing the cities and going off into the woods to hide. And then many refugees were crossing over into Cross River State in Nigeria. A colleague of mine is on this call, and he was working MSF also with those refugees in Cross River, Nigeria. And we were trying to figure out a way to do that cross-border work to make sure that the care was constant across the way and that we could service everyone. Unfortunately, for lots and lots of reasons, we were unable to ever make that happen, but that is often an ideal, so that we have a continuum of care from being an IDP to being a refugee. So we did the same thing here. I was there as part of the first team. We went and did an expo in which we were doing what we call expo action. So trying to figure out what the needs of the community are by offering primary care. We did mobile clinics within town and in rural areas, and trying to identify those major health needs. And like I said, Cameroon has a pretty sophisticated health system, and we found that most people were suffering because they lost the ability to treat their chronic conditions, right? And which is interesting, because as a mobile clinic, we were offering malaria care and the basics, like things that I told you about. So we did not have the things that they needed to treat their hypertension, their diabetes, their heart conditions. And so really understanding that we had to change our strategy from what we were used to really try to meet those needs, or to support the local health systems that were still functional. A big problem at that time also was that the health system was destroyed. The health system was targeted in this war by both the government and by the rebels, in which health clinics and healthcare providers were destroyed, were targeted, and by the rebels, as well as harassed by the government. And so it really became a key problem that people weren't actually able to access the care, and made it really complicated in order to reach the population. But what we did find out by conversation after conversation with people is that we dealt with a lot of adults that were coming complaining of headaches, eye pain, stomach aches, constipation, and difficulty sleeping at night, and feeling hot and cold. And so I always remember them telling me, I feel hot and cold and I have waist pain. And I really we were able to see that these were a somatization of the trauma that they were going through. These are professionals, they're farmers, they're teachers, nurses, who suddenly their whole life is destroyed when the government comes in and retaliates against the rebel action and burns down their village and their farm, and they're forced to flee, that they are going to feel really horrible. And so we, although from the headquarters in Europe, they were like, you need a midwife down there to help you with reproductive health care. And I was like, absolutely not. What we need is a bunch of mental health professionals, because that's actually what they need. The system here has midwives. They can actually do most of that primary care and secondary care, but what the population actually needs are some mental health services. And the population was actually really open to it as well, and welcoming of that and able to talk about it. So these are just really, obviously could go on and on about example after example, and talk about the exciting work and also the real challenges of working in these places, which are often very remote, and difficult to get to, and difficult often to find the populations that are in need and to build those relationships in order to serve them. But I am going to hand it over to Rohan, and so that he can talk about what happens when these people, and if they eventually do get resettled in the United States. And then at the end, I'm around for questions. So
thank you, Rebecca. And I just want to remind participants to please write your questions in the chat, and we will answer them after Rohan's presentation. Thank you. That was great.
Thanks very much. So I'm not sure if I still have control of the slides, or Rebecca, will you continue to? Okay, all right, cool. Awesome. Well, thank you so much for joining our conversation. I think even as sort of a background to the preparation around this is that both myself and Rebecca were reflecting on our experiences of doing this type of work, both here in the United States and abroad. And we found out that we actually happen to be working in some of the very regional areas and countries, perhaps not at the same time, but we actually were sort of touching base and doing things with some of the similar populations. My approach to this also too is the idea, particularly having done refugee work overseas in Tanzania and Namibia, was that when I came back to the United States and took on this sort of faculty role, was to sort of promote the idea that local health is global health. And so we don't necessarily have to go overseas to deal with issues around immigration, refugee or asylum seekers, but these realities are things that are happening here in the US as well. The next slide. So what I'm talking about today is really kind of situating how do we look at the issues that refugees and asylum seekers encounter once they have arrived in the United States. And that can be from the day at which they arrive to 10, 15, 20 years later. These are some of the things that we see happening. And there's never sort of an end point at which it no longer influences. But in general, most refugees and asylum seekers do have profound changes that they have to go through in terms of altering the ways in which they have lived their life in the past, leading to a host of practical and social coping challenges, including difficulties achieving their life goals, difficulties attaining environmental mastery in a new place, poverty and daily concerns about economic survival in a new country, loss of community and social support, and a reduction in sort of meaningful social relations within the the resettlement center. So just think of it, one day you're in your community overseas, everything is normal, and then ultimately you're just uprooted. And sometimes your family is totally disrupted by the process and you don't know where each other is. And then you're then landing into a new place. You obviously are sort of happy and pleased with the fact that you are in a safe, secure spot and also given a chance for a new life, but you have no idea what you're getting into. And so therefore that becomes sort of problematic and becomes very hard for many folks to sort of deal with. It really puts them at a disadvantage when it comes to being able to maximize their full potential. Next slide. So what we've seen over years is that studies have really begun to show that there's a cumulative effect of migration trauma. And that also differs for refugees than it is for other immigrants or non-refugee communities that are resettling in the countries that are hosting them or are accepting them. Particularly in the United States, issues such as limited access to healthcare or mental health issues, delayed use of prenatal care, and as well as also high preterm birth rates are all issues that we tend to see occurring within refugee communities. Next slide. And so one of the things that I'm most particularly interested in is sort of really understanding the daily stressors. And what we sort of define as daily stressors include the safety concerns, the stigma, discrimination, language and educational limitations, the under or unemployment, and the lack of access to sufficient resources that people encounter and deal with on a daily basis while trying to start a new life, or even while having a new life in the country, but still encountering these challenges. And thinking about this in the context of the fact that they also are dealing with the migration trauma they've already received or have dealt with prior to coming to the United States. So this is sort of a cumulative effect that ultimately folks have to deal with, that oftentimes when we see refugees working or interacting with us, we don't necessarily automatically assume that all of this is all things that they are ultimately dealing with and walking around with. Next slide. So as we look specifically at the numbers in the United States, we see that one of the things that we see is that actually almost more than 50% of the refugees that are resettling in the United States would be deemed as sort of racial or ethnic minorities individuals, but more importantly, they are also men. What we're also seeing is that where they're locating, resettling are also changing too. So the historical centers such as New York, Chicago, Florida, and California, they're still there, but they're not necessarily going into those urban settings. We're starting to see refugees settling into sort of mid-sized cities, rural communities, and contexts, and those communities don't necessarily have the history or the resources that other places have historically resettled refugees. And so that also conflates to the problems and issues that they encounter. Next slide. So what I've seen through this work is the gaps that we need to know more about as a way to be able to better serve these individuals. Is that research about racial and ethnic minority refugee men represents a really important nexus of key issues that are overlooked and understudied. And more importantly, delineating their health and well-being, particularly as it relates to race, gender, and ethnicity, have not been extensively studied in the United States. And I think that that's really critical for us to be able to understand how both they understand their health and also act upon their own health, but also to how they engage with the systems that embody some of the sort of issues and challenges. So next slide. So with this work, I really sort of use the approach of intersectionality, which really sort of posits that social structures which shapes aspects of identity are constitutive, and therefore one can be privileged by one axis, such as race, ethnicity, sexuality, or ability, yet marginalized by another, whether it be immigration status, language proficiency, or even having some degree of impairment. Next slide. And so one of the things that's really critical about intersectionality, it really sort of puts a critical lens on the issue around power and how it influences access to resources, and then how that influence also ultimately comes out with influences health outcomes. We pose that those with the least power and least access to material resources tend to have poorer health outcomes. Next. So in recent years, intersectionality has been really applied to men and men's health. And really sort of to elevate the unique experiences of particularly ethnic, racial, and gender minority men, where it sort of notes that certain groups of men that shared characteristics, whether it be aboriginality, disability, gay, transgender identity, or racial and ethnic heritage, are generally identified as marginal or subordinate vis-a-vis other men. And evidence shows that men with such groups generally have poorer health outcomes that we need to consider. Next slide. And so in this work that I am doing, I'm really sort of applying this approach to really understand how does migration trauma, being labeled as a refugee or asylum seeker, also coming to the terms with the identity of being known as a racial ethnic minority man, and the daily stressors that embody American attitudes about race, ethnicity, gender, and immigration status have an influence on the outcomes of the refugee men that have resettled the United States. So really is to really understand their intersectionality. And more importantly, I think that we need to also understand that the experiences of ethnic minority refugee men is different than that of the historically noted minority health issues that we tend to see in the United States. And therefore, the argument of this work is that we really need to pay closer attention to the experiences of being a refugee or asylum seeker, in addition to also being noted as a minority or person in the country. So since 2015, and also again in 2019, I've been working on initiatives such as the Chicago Refugee Men's Health Initiative and the Quad City Refugee Men's Health Initiative, which really focused on trying to promote health equity for ethnic minority refugee men in the United States, Chicago is a historical urban center that have resettled and have embraced refugees and immigrants. I think the name for the city is the city of broad shoulders. And then, we also position that against another part of the state, which is called the Quad Cities region, which is on the border with Iowa. And it's more of a semi-urban, more rural community. And in recent times have recently begun to accept the resettlement of refugees in that area. So through my work, I'm trained as an anthropologist, and so therefore I really focused on qualitative methods to really kind of understand and discern the kind of issues that I really was interested in. So the use of life narratives was one of the main focuses that I used to engage in conversations with men. And we talked a lot about issues around their migration journey, the trauma exposures, navigating daily stressors, and then their past and current health and well-being status. In addition to that, I augmented that by also inserting myself into the community, and particularly within the common spaces where men tended to congregate and socialize, as a way to help to sort of contextualize their experiences along with the narratives that they were sharing. Next slide. And so one of the first studies that I really wanted to kind of share with you is really talking specifically around how American attitudes about race, ethnicity, and gender affected their health and well-being, particularly for Black African refugee men in the United States. Next slide. So some of the things that I noted, particularly among the subjects of this study, was this notion of what I describe as the continuum of trauma. And in Polly's reflection, he says, typically I had a lot of cousins, but they died in the Civil War. One of my older brothers got mentally ill because of his experiences during the war. Today, he still suffers quite a bit. Most of the help and support we try to get him hasn't worked. I don't think many people out there can understand what he's feeling and how it impacts his life. After the war, he has never been the same, which has affected him in terms of having a normal life here in the United States. So we can look at this in two ways: the burden that it has on the family, that potentially they will be responsible in having to look out for this individual for the rest of their lives, but also he is within a system, and as Rebecca was talking around mental health, they didn't fully understand his previous exposures as a refugee, the trauma exposures that he had, and how that still continues to affect his ability to be independent. Next slide. So one of the things that I also was very much interested in is also how do they come to understand their identities as individuals within the United States? And the DIFA says here, it's tough because identity is something that you define with yourself and your family. However, it is very different here in American society because your identity is attached to your skin color. If you're Black, it assumes that your status is lower and different, causing you more stress and concerns. I know I'm racially profiled and targeted. I say to myself, if I were white, maybe I wouldn't have this kind of feeling. It affects my well-being because it causes stress. But it's something that I must understand about America, and that's his way of trying to cope and deal with the situation. Next slide. When we look at particularly health and well-being, we see from Tahil, he says, if you have a better job, you have better health care. If you have better health care, you have a chance to see the right doctor every time. Once you see the right doctor, you will be better off. If you don't have health insurance, you might suffer and then can excel into a severe problem. Later, you might die easily without health care, and those are the things that I worry about in America. And so I think even just seeing how he also is starting to embody and realize that these are things that we ourselves think about every day, in terms of having the right type of healthcare insurance or coverage to be able to access the right type of care, are things that now also these individuals are having to worry about themselves. Next. So looking specifically at encounters with American attitudes, and the American attitudes that's sort of captured in this study is really around issues around race, ethnicity, gender, and immigration status, and things that people naturally sometimes are just invoking or assuming of individuals. And it's basically become the fabric of how we sometimes look at individuals. And so Filson says, I had to find ways to succeed. We lost some aspect of ourselves as refugees, but gained freedom in America. While we appreciate a new life in America, it's not easy for a Black person trying to exist. I'm constantly aware of police profiling, and at times I change my daily routines to ensure that I can be around for my family. So this is something that someone has never had to deal with prior to coming to the United States, and now looking specifically at having to deal with these issues on a regular basis. And also thinking about it from the standpoint of it's part of his survival tactic to survive and live and be successful in the United States. Are things that now he has to think about. Next slide, please. And another story is RuPaul, where he says, but when I'm stopped by the police, they don't say, oh, he's East African, so he's different. Instead, I have to realize that they will always think of me as just Black. Being an African-American male, some days I like to disengage myself from the category when it comes to health, because things are never going to be in my favor. If I have the slightest change in my health, I take care of it. I have started going to the gym, watching what I eat, and staying in good mental health. One of the things that we noted in the study, where we weren't routinely doing vital signs among the subjects, but we did ask about their health status, and the common things that many of these very young men are talking about. They've been reported to have high blood pressure, been diagnosed with diabetes, and extremely high stress levels are all things that they routinely identified as being issues that they are dealing with at this stage in their life. And much of that is tied to in terms of just how they are just living with and dealing with the environment. And so then we also look at how do they go about embracing their identities. And so Fubu goes on to say that I've learned to embrace my identity as Black African-American, but again, it is not the same, for me as it is for most other Black men. There is a distinction. There's the African-American experience, which is completely different than what I've experienced. They didn't come to this country by choice. I wasn't brought here by force and enslaved, and they have generations of cultural legacies. I came as a refugee. So while they do see some level of connection to generally most African-Americans in the United States, they also see that there is a distinction. One of the things that we've learned over time is that they do, as generations go on, they eventually begin to assimilate much more quickly to those particular groups than they do for those who are just recently arrived. And so therefore you would see children tending to more gravitate to those identities. Next slide. So something that I particularly was not looking for, but I could not ignore the fact that this emerged in this work, is just how American attitudes after 9/11 has now still permeate the ways in which particularly these East African refugees have come to terms with and understand. So after 9/11, where the profiles of the perpetrators of the incident were mainly categorized as being Arab, Muslim, Middle Eastern, East African, there was this degree of hypervigilance towards any man who sort of looked like that. And so therefore, most of these individuals either arrived or came into the United States with an understanding around the fact that this is a target that they have to deal with. And so therefore, they've had to really kind of embody that as part of the daily stressors of not just only being perceived as being a person of color, but also to being someone who is also identified with sort of these sort of hypervigilant sort of expectations around what appears to be someone's either racial or ethnic or religious identity. Next slide. And so adjusting to life is part of the first summary to this particular study. Is adjusting to life in the United States requires individuals to really understand and learn how to navigate American attitudes around race, ethnicity, gender, and immigration status, which I don't think most resettlement agencies and programs do think of this as being a priority, but it is a reality that which people have to deal with. And so therefore, these are things that we have now noted that American attitudes most commonly related to, most of these attitudes are usually related to issues around housing, employment, healthcare, and education. And we do see, and I think it requires further research and study, is the sort of correlations to diabetes, high blood pressure, stress, and sleeping disorders that we see. And then learning about these issues and coping about these, and learning about the issues and coping and adopting coping strategies are things that we notice that the men are looking within or are generally finding resources within the community. And so therefore previously arrived refugee men who've been around for maybe 10, 15 years or longer, they have now become this sort of individuals that are helping these other, the new early arrived individuals come to terms with this stuff. What is also interesting too about this is not specific to any particular ethnic group. So with some of the East African men that we were working with in this study, they told us about how like Syrian refugees who came 30 plus odd years ago were offering advice and perspectives around how to navigate some of this stuff because they experienced it when they first arrived. And so therefore it's not very specific to each cultural group. Next slide. So, you know, as Rebecca indicated early, we talked a lot about the whole notion of statelessness, and another part of my work has been with the Rohingya refugees. Next slide. I'm also being cognizant of time here. So the Rohingyas are a Muslim minority in the country of Myanmar. In 1982, Myanmar rejected or denied the citizenship to these individuals and have now deemed them as being illegal immigrants. And due to the constant violence, not only in terms of structural violence, but also to physical and harm, a lot of Rohingyas have fled Myanmar into neighboring countries, particularly Pakistan, Bangladesh, Thailand, and Malaysia are all places that they have moved to. Next slide. So like I said, they've been denied rights to vote, rights to access to documents, or any other sort of official certification that will sort of give them the ability to say who they really are. And so that has been sort of a government-sponsored sort of genocide that has had a tremendous impact for many generations. Next slide. So Chicago is one of the few cities and places in the United States that have resettled Rohingya refugees, and is actually now the first Rohingya cultural center that was established in the United States was here in Chicago and emerged out of some of the work that I've been doing here. But things that we have been able to identify is the fact that the financial hardships that we see individuals encountering or dealing with has connections back to their previous life back in their home country. So not having access to complete education, and for those who do go on and get education, not being able to get a high school certification or diploma. And so that when they come to the United States, the opportunities for them to be able to get jobs are very much limited. And oftentimes the jobs that they do get are high risk, low paying jobs. And so therefore you can see in this particular quote that this person really sort of makes the connection between his previous experience and how that has translated into his current life now. Next slide. So then there's also this notion for a community and a group of individuals who have fought so hard and through the generations to really preserve and maintain their identity. They are now also coming to this notion of acculturation tension within the United States, where their younger kids and kids are more likely to assimilate to American life and identity, unless so around their Rohingya cultural identity. I remember even having conversations with kids, and we would ask about, you know, how would you identify when you're in the schools? And they would oftentimes say, oh, I'm an American. And the parents would get really upset with that because they're like, well, you're also Rohingya too. And we fought really hard to try to maintain that identity. And so therefore that oftentimes causes some tension, family tensions within the family and within the household when it comes to these issues. And then acculturation. Participants reported that adjusting to life is a tension between also maintaining their identities and that of others. While also embracing and accepting their American identity. So those are things that they constantly deal with. And particularly this is unique for a group that has, for a very long time, has been forced to try to avoid identifying as Rohingya or identifying as Muslim. Next slide. And so the impact on health, when talking with a lot of the men, reports of sorrow, nightmare, sleeplessness, dizziness are things that they all talk about. And we also have to put this in the context that while many of them have resettled here into the United States, many of them, their families are still back in Myanmar, or in recent times, there was a large exodus and push to Bangladesh, where a lot of refugee camps were settled. Were established because of the huge migration. And in the last months, we know that Myanmar is going through a very interesting civil war kind of process with the military now having taken over. Next slide. So we've gone through this, I'll leave this as that. Another thing too about this work is the US policy towards refugees and immigrants. When I started this work, new administration had come in, and then there was all these caps around refugees, and particularly the caps and the restrictions were limited to a lot of Muslim or Middle Eastern countries. And for many of the subjects that I was working with, that was another heightened concern and frustration for them. Even though Myanmar was not on that list, many of them, the Rohingyas, really felt like they were once again in this process of being persecuted as a result of this. Next. So the questions that we wanted to sort of end on by or sort of putting out there, and we can have further discussions, is how do we provide uninterrupted support to these populations, and how do the lack of coordination of care impact individual and public health? And just some points that I have listed here in terms of is that the new challenges, the refugee and asylum seekers are being resettled into cities, towns, and communities that do not have the history of resettlement. So that limits the capacity of some individuals and agencies to be able to understand the dynamics. Most people don't realize, and I didn't know this until I really got into this work, that most resettlement agents resources have a time limit. I think in most instances, it's usually within 9 months that all the support and resources usually gets cut off. Many folks may not know is that they also have to pay back the money of them, traveling to the United States, something that I was not fully aware of until I started doing this work. And then the notion of that there's no singular template for providing services. And that sort of use of the singular template is sort of problematic, it's insufficient, and it also doesn't get to the sort of fundamental issues that we saw earlier when it comes to issues around race, gender, ethnicity, and immigration. And then there are long-term implications. How does the lack of coordination care impact individual and public health? As we see through this work, trauma does not end when resettlement is completed. And then we're also noticing that there are emerging refugee-specific health issues that are not apparent within larger discourses around minority health. And particularly in terms of how do refugees and asylum seekers relate to a process and deal with American attitudes. And then the framing of coordination of care really needs to take on more sort of an intersectionality approach to really understanding the multi-layers of identities and powers that are at play here. And I don't think we fully have understood and sort of maximized the potential and impact of communal interventions, rather than sort of taking on the more singular approach of trying to deal with mental health, either by prescriptions or other sort of individualistic kind of approaches. We really need to start thinking about how we can both engage the community, but also to work within the community, and potentially, as we saw, folks who've been around a lot longer be resources to individuals who are newly arriving. So those are just some points that we kind of wanted to end on and give you a chance to be able to open up and ask questions. I think there's some questions in the chat.
Oh, Tonda, I think you're unmuted. I believe the first question that was asked was from Veronica. She asked, what kind of resources are available for small independent clinics working with refugee communities at borders? For example, funds to support electronic medical records, infrastructure, health assessment, best practices for mobile marginalized population, etc. I think this question was for Rebecca.
Thank you. That's a fascinating question. So generally, in my experience, that the responsibility for the health of refugee populations does fall on the host country. And so they offer up services to the best of their ability within the systems that they already have of both publicly funded government government health services, as well as any other local NGOs, church-based, however their health system works. And so then it ends up being a real strain. These systems in the places where I have worked, which are low resource settings and very low resource settings, these are already precarious systems that are working on a fee for service. And so, you know, the refugees often don't have money in order to feed into that system. And so basically what it ends up happening is that were it not for international NGOs coming in and supporting either the local health systems or setting up their own health systems, that there would be no care for refugees, even for refugees that settle. I've worked with South Sudanese refugees in the Democratic Republic of Congo who refused to go into camps and lived in a border area that had been depopulated because of the war in Congo. And so there were at local health centers, but they couldn't access it because they didn't have any money. And until the international community came in and gave vouchers to the refugees that they could spend at the health center so that the health center could get reimbursed by these private funds, that they were just not going to get any health care. And so I think that, you know, the funds are private funds, right? And so UN, international NGOs, you know, and these are, I mean, severely underfunded in general, you know, that's not happening. And I think that one thing I was talking to my friend about sort of these minimum standards, and I think we, you know, they're pretty minimal, but also oftentimes it's really just about good enough. You know, like it is just such an emerging situation where we just need to treat people for malaria or, you know, give them, you know, help them deliver their baby or treat them malnutrition, whatever it is. It is such an emergency that like sort of having best practices from, you know, marginalized populations, like, wow, I would love to be able to do that. And at the end of the day, I think about it, but in the moment, we're often not able to think about those things. So yeah. And I have never worked anywhere with an electronic medical record. So that just putting that out there. Sounds great.
So particularly within the US context, one of the things that we see is that the FQHCs, the federally qualified health clinics in a lot of these communities tend to pick up and fill the gap. So therefore, they're the ones who then have to provide most of the resources for refugees within US context. And usually they tap into resources that would be allocated specifically by the CDC or Department of Health and Human Services that would be allocated to the state. And then the state would then redirect those funds to either the state health department, local health department. And so therefore, there are opportunities for agencies and local health departments to apply for specific grants and resources to be able to support them. When it comes to electronic health records, the Affordable Care Act has been that sort of way to build that bridge when it comes to the electronic health records for refugees, is the resources within the Affordable Care Act have helped a lot of these clinics to be able to adopt and engage in that practice.
We're really out of time, but there was one more question that a person, and my computer died in the middle of this, so I don't have her name, but she wanted to know if you had ideas about resources for reproductive health care for refugees. And if the person is still on and wants to elaborate on that question, please do so very quickly.
It's from Candace Hugo. Resources for working with migrant women who are experiencing pregnancy that is a result of rape.
Oh, yeah.
And yes, Candace is still on.
Well, I won't defer to Rebecca, but I know there's a couple trauma centers. There's one here in Chicago, and I know a couple other urban cities around the country have very trauma-specific centers. And I think within those sort of framework, within those sort of settings, you have the option of sort of accessing resources. I don't know if they're ever tailored specifically towards women, but I know they have trauma centers, resources for refugees and asylum seekers.
Yeah, that's what I was going to say. I think the Centers for Victims of Torture up in Minnesota, Minneapolis, has a real rich place for resources for dealing with for all sorts of issues. So they might be able to have it. Also, depending on where you are, there are OBGYNs that have sort of, or midwives that have directed their practice towards working with refugees and working with asylum seekers, and they would also be a rich resource for you. If you want to directly email me, feel free, and I can see if I can hook you up with someone that I know in my world, if you happen to be in a city where I know someone. So yeah. I can put my email in the chat.
And while Rebecca's doing that, I quickly wanted to respond to one question, because I know this triggers a lot of people they don't know about, is the paying back. People don't realize that refugees and that arrive in the United States, they're given a travel loan to come to the United States. And then when they arrive, they're required to pay back the government for that travel loan. So thinking about, like, you don't even have a job, you don't even have housing, whatever, but then you have to pay back the government for the travel loan. And then when that doesn't happen, it triggers issues with your credit. So now that you go and try to open up your first bank account or purchase your first car, and you have a credit history that's not good because you haven't paid back the loan, that sort of creates a sort of a disadvantage for some of the refugees.
Is there a time, what is the time frame, Rohan?
Generally, it's been like within the 9 months of them arriving and when the services, but I don't know. I think it might be negotiable to the government, but the longer you wait and not do it, interest comes up and becomes a problem. Yeah.
Right. I don't think we can take any more questions because we're over time, but thank you all so much. There was a number of complimentary comments in the chat. I learned a lot from this presentation, so I really appreciate your taking the time to present. And everybody, please do stay tuned for our next Global Health Nursing presentation. Thanks, everyone, a lot.
Thank you.
And thank you for the opportunity. And thank you for coming.
Yeah, awesome.
Thank you.